So welcome back to Pharmacology with Dr. Sokolow, and in this module we are still going to talk about pharmacodynamic, and more specifically we are going to talk about dose-response relationship. So on this slide we are going to talk about the basic features of the dose-response relationship and what does it mean. So how do you quantify the dose response and how do you understand that relationship between the drug and the biological effect it produces? So this is usually plotted as a dose response curve like you see on this slide. On the x-axis you see you have the dose, and on the y-axis you have the response, and you see this dose response curves are useful for describing the effect of the drug. And you see that this has three phases: phase 1, phase 2, and phase 3. So you're probably wondering why there are three phases in the dose response curve, and so the reason why is because of the simple occupancy theory. So that theory states that the intensity of the response to a drug is proportional to the number of occupied receptors by that drug, and that the maximal response will occur when all the available receptors have been occupied. So if you look at this figure, so you see at the bottom of the curve you have only like one little ball that is occupying the receptor, so that's phase 1. And then when you have more drugs that are occupying the receptor, you see that's when you have the steep increase in that response, and that would be phase 2. And then phase 3, that's when all the receptors are occupied, and even if you have more drugs that are added, because all of the receptors are occupied, the response is just plateauing, and that's the third phase. But in reality, there are other properties of the drug that has to be taken into consideration when you look at the occupancy theory. And so this is the modified occupancy theory that describes two qualities of the drugs. The first one is called affinity, and the second one is called intrinsic activity. So what is the affinity? The affinity is the strength of the attraction between the drug and its receptor. That means this tendency of a drug to bind to a receptor. So as an example, you can refer to like a key and a lock, and so how well the key, will fit to the lock. And so that's the same thing with the drug and the receptor. If the drug fits perfectly into the receptor, you're going to have a high affinity, and drug with a high affinity are going to be very potent because they're just like a perfect match for that receptor. Now the intrinsic activity is the ability of a drug to activate its receptor upon binding. So not only you have to have that drug that fit to the receptor, like a key that fit to a lock, but you also need to have that key to be able to open the lock. And so that's what is the intrinsic activity. It's like the ability of the drug to activate its receptor upon binding. So a drug with a high intrinsic activity causes an intense receptor interaction, and the intrinsic activity of a drug is reflected in its efficacy. So the maximal efficacy is the largest effect a drug can produce. So if you look at this slide and you see you have a dose-response relationship with two different dose-response curves for two different drugs. You have meperidine in red, and then you have pentazocine in bluish. And you see that meperidine, the curve is, higher than pentazocine. And so the maximal efficacy is indicated by the height of the dose response. So you see that the plateau, so which is the maximal response, is higher for meperidine, and so therefore the height of that curve is going to be higher than the maximum height for pentazocine. So that means you have meperidine is more effective in reducing pain than pentazocine, and so it's an important characteristic of a drug because if you look for a painkiller, you want to know which painkiller is the best for treating pain. So in that situation, you see that meperidine compared to pentazocine, that meperidine has a maximum efficacy that is larger, and so that also means that at the same dose, you see for the same dose, meperidine will produce more pain relief, because on the y-axis this is the degree of pain relief. So if for the same dose, because the dose is on the x-axis, and so if you see where those arrows are pointing, that would be the dose for each drug, but you see that meperidine has a higher dose response, so that means its maximal efficacy is higher than for pentazocine. Now, potency on the other hand, so the relative potency is the amount of the drug needed to elicit an effect. And so again, if you're looking at this dose-response relationship, you see that the potency is going to be indicated by the relative position of the dose-response curve along the x-axis, because this is the amount of drug needed to elicit an effect. And it's actually referred to the concentration EC50, or the dose ED50 of a drug required to produce 50% of that drug maximal effect. So you see for morphine, you have the blue curve. The maximal effect would be when the drug is plateauing. So 50% of the dose needed would be halfway to the maximum. And so then you read on the y-axis the degree of pain release that is produced at 50% of that dose response curve. And then you read the dose on the x-axis. Now for meperidine, you see that you're going to need a stronger dose to produce the same degree of pain relief. So that means if you need less morphine to produce the same effects, the same pain relief as meperidine, that will indicate that morphine is more potent, because you need less drug to produce the same amount of pain relief. And so that's the potency. And so on this slide, these are the same two drugs, so morphine and meperidine. This is the same graph as the previous slide, but just to tell you that the more potent drug produces the same response at lower concentration. Because again, you have to look at your x-axis and see which one needs a smaller dose to determine which one is more potent. So more potent, which means you will require to give a smaller dose of that drug compared to the others. So morphine, you see you need a smaller dose to produce the same degree of pain relief as meperidine. So if you're on your x-axis, let's say you have 0 and then 10 and then 20, 10 would be 10 for morphine and then 20 for meperidine. So you only need 10 milligrams, let's say, to produce a pain relief with morphine, while you would need 2 times more to produce the same response with meperidine. So morphine is more potent than meperidine. So on this slide is just a comparison between efficacy and potency to make sure you understood the concept. So you see on the left you have efficacy. So remember, is the height of your dose response curve. And so when you see those two drugs, you see that the height of meperidine, of the dose response for meperidine, is larger than the height of pentazocine, of the curve of pentazocine, the maximum height. And so that means that meperidine has a greater efficacy than pentazocine. Now for potency, if you look at the two curves, so morphine and meperidine, in order to determine the potency, you have to look at the ED50, so the dose that produces 50% of the maximal response. And you see that the dose for morphine is smaller than the dose needed for meperidine to produce the same degree of pain relief. So that means that morphine is more potent than meperidine. So there are a couple more concepts that I need to explain before we move on with pharmacodynamic. The first one is the full agonist. So if you remember, I said that most of the drug bind to receptors that are used by our endogenous molecule. And so full agonist will mimic the effect of that endogenous compound, like acetylcholine. So a drug that is a cholinergic will just mimic the effect of acetylcholine. And in that case, it has an affinity, means, fit well to the receptor, and an intrinsic activity, is able to activate that receptor. And a full agonist will give 100% of the response, even if it doesn't bind to all the receptor because of that intrinsic activity. Now, partial agonists act the same way as a full agonist. They're going to act on the same receptor, but it doesn't have the maximal effect. Even if all the receptors are going to be taken, you're not going to see a maximal effect like you see with a full agonist. And the reason of that is because the drug has less intrinsic activity, and also they have a mixed effect. They have an agonist effect and an antagonist effect. And so in the next slide, I'm going to explain what an antagonist is. So an antagonist, as opposed to an antagonist will bind to the receptor but has no intrinsic activity. So that means it cannot activate the receptor, and actually is going to block the receptor and is going to block the action of the endogenous agonist. So it has an affinity because it fits, well in the receptor, like your key would fit in the lock, but then it just doesn't move, so you cannot open the lock. So that's what an antagonist do. Just occupy the receptors and block the effect of the endogenous agonist that cannot, bind there. And so you have an affinity but no intrinsic activity. And now there are two more concepts, which is competitive inhibition and non-competitive inhibition. So the competitive inhibition can be overcome by increasing concentration of agonist. And the non-competitive inhibition, it's irreversible and it's covalent, so you cannot overcome the inhibition by increasing the concentration of the agonist. And let me explain this on the next slide. So here you have an example of a full agonist, partial agonist, and antagonist. So these are three opioids or opioid antagonists, and it just shows you the dose response of those three drugs. So first, let's talk about the full agonist. You see the curve with the red square. So this is methadone, so it's a full agonist, and these are going to bind to the opioid receptor. And if you increase the dose of methadone, you see that you have an increase in the opioid effect. So the dose increase, the dose is in the x-axis, and then you see on the y-axis, you increase the dose, you increase the opioid effect. Now the partial agonist, because a partial agonist cannot produce a full response, you see that if you increase the dose, your curve is plateauing. So after, let's say, the 5th dose, you see that the 6, 7, and 8, the response doesn't increase, and that's because it's a partial agonist. No matter what, you can increase the dose, you're not going to have a stronger effect because it has less intrinsic activity and it has some antagonist property as well. And now you have your antagonist, which are the triangle on the x-axis. So naloxone, which is actually given in case of overdose with an opioid. So somebody would just, overdose with opioid. You'll give this to reverse the respiratory symptoms. And so naloxone will bind to the opioid receptors. And because it's an antagonist, it will just, fit to the receptor, but it's going to produce no response. And indeed, because it binds to the receptor, also going to prevent the action of the agonist. So in that case, you see you have no response, because if you look on the x-axis, you see that naloxone is totally on the y-axis is totally flat. So you increase the dose, which is on the x-axis, and then you have no peak. You see the dose response is flat because it has no opioid effect, and that's an antagonist. Okay, on this slide you have dose response curves in the presence of competitive and non-competitive antagonists. And so let's start first by non-competitive antagonism or non-competitive inhibition. So look first at curve A, so the tallest one in blue, and it's A, it's an agonist alone. So if you remember, an agonist is able to produce 100% of the response. It's like the maximum response is going to be seen when you have an agonist alone. B is like when you have that agonist, let's say it's called X, and in presence of an antagonist called Y. So if you have X alone, you have the maximum response, but now you have Y into the mix, and the problem is like Y is going to sit on some of the receptors that were used before by X, and X is not able to kick it out. So Y is sitting there, and you have less, receptor available for X, and so therefore the response is going to be smaller because you have an irreversible inhibition competition. You have so here you have dose response curves in presence of competitive and non-competitive antagonists, or competitive and non-competitive inhibition if you want. So let's look first at figure A, which is the non-competitive antagonism. And so in figure A, you see you have 4 different curves, A, B, C, D. A in blue is the agonist alone. So let's say it's drug X. So drug X alone, or it's your endogenous ligand alone. So you see that's the one that produced the maximum response because that's your full agonist. Now if you on top of X, you add drug Y, which is an inhibitor, and that inhibitor is bind to the receptor, and it's a irreversible binding. It's like a strong binding. Now you're gonna have your X that is gonna bind and sit to some of the receptors, and now X are gonna have less receptor available, and even if they occupy those receptors and have intrinsic activity, because some of the receptors are occupied by Y, you are going to have a smaller response than when X was alone. And C is the same response as with B, where you have your agonist and your antagonist, but you give more of your drug Y, so more of your antagonist. And because you have more antagonist that sits on those receptors, X is not able to produce, the same response than before, and so that's why your curve is smaller. And then D is just the antagonist alone, because we saw that an antagonist cannot produce a response. It doesn't have an intrinsic activity. So D is drug Y by itself, and you see has no response, is totally flat. So that's the case of a non-competitive antagonism. So X is not able to kick out Y once you have your antagonist. Now the other one is a competitive antagonism, so that's in figure B. So you see you have 4 different curves, but instead of having smaller, instead of having like different height, they all have the same height. And so why is that? So A again is your agonist or your drug X or your endogenous ligand by itself. And so you see you have maximum response, and then once you add B, in this case, because it's a competitive inhibition, your drug X is going to be able to kick out your drug Y, but to produce the same response, you're going to need a stronger, a larger dose. So that's why your curve is shifting to the right. If you compare A and B, the curve shift to the right, because if you look at your x-axis is the dose of agonist that you need. So in order to produce the same dose response, and because it's a reversible inhibition, it's a competitive inhibition, your agonist is going to be able to overcome this, but you're going to need more agonist. And now C is the same, but you have even more antagonists. So then again, to produce the same response, your agonist, you're gonna need a larger dose of your agonist to produce the same response. And so that's why the dose, if you look at the x-axis is the dose of agonist, so you see you need more of your agonist and your curves shift to the right. And then D again is your antagonist alone, so you see the curve is flat, is because it's just the antagonist. So try to play with that and understand the difference between a non-competitive antagonism and a competitive antagonism. Now, the last thing you need to know about pharmacodynamic is the inter-patient variability in drug response. So, patient respond differently. Maybe patient A will need more of a drug to see the same amount of pain reduction. And we are getting to, personalized medicine, but we are not there yet. And that's why, when the dose is determined in clinical trial, is determined to give like a safe dose that will provide, the less harm to the patient. And some patient may need a stronger dose than other to see the same effect. And in order to determine like the safety of a drug, there is a term called the therapeutic index. And so the therapeutic index is actually the ratio between the LD50, which is the average lethal dose, which means the dose that is lethal to 50% of the animal tested, because of course, we don't want to kill 50% of the patient during a clinical trial. And so that lethal dose is kind of determined in preclinical study and in animal. And the ED50 is the average effective dose that, they see that is effective in 50% of the patient that were tested. So that would be the average effective dose, and that's the dose that is required to produce a defined therapeutic response in 50% of that population that was tested during the clinical trial. And then the therapeutic index would be, the ratio between the two. So if you look at drug X, which is on figure A, you see the ED50. So again, on the x-axis, you have the dose. And so that drug, with 10 milligram, you see a maximum response, in 50% of the population that was tested. And that's what is, that's your ED50. And then on dash green is like the LD50, which is 100 milligram. And that dose, was the dose that was causing, it's lethal, but it's not, not necessarily like killing the animal. It's really like causing severe adverse reaction. And so here you see that 100 milligram was causing severe adverse reaction in 50% of the population that was tested, 50% of the animal that were tested. And then when you reconciliate the two, that's what you have, the therapeutic index. So 100 divided by 10, it's equal 10. And now you see drug Y, it's less safe because the dose that, produce a response in 50% of the population, it's only half of the dose that cause, severe adverse reaction in 50% of the population, because here your ratio is 20 divided by 10, so it's only 2. So you only have like a slight margin. And so drug that has a small therapeutic index are the drug that you're going to have to monitor closely when it's given to a patient, because, a slight change in that effective dose can, cause adverse reaction. But a drug that has a high therapeutic index, and that's most of the drug, if a patient require, a larger dose, because when it was determined again, in the population of the clinical trial, 50% of the patient, show, efficacy, but you see you have some that are on the bottom of that bell-shaped curve, needed maybe 20 milligram to see the same effect with that drug X. So for them, if they need 20 milligram, if you give 20 and the therapeutic index is 10, so you see you are far from seeing an adverse reaction. On the other side, if the patient is taken drug Y and requires 20 milligram to see, a reduction of its symptoms, you are overlapping with the green dash curve that is the lethal response, or like the adverse reaction response. And so they would need to be like closely monitored for any of those side effects with patients who are not the average responder of how the drug dose was determined during the clinical trial.